The first talk is The Natural History of Degenerative Spinal Surgical Pathology as presented by Joanne Chambers. Thank you.
Hello, my name is Jo Chambers. I work as an APP within the neurosurgical department here at within Glasgow. So thank you for the opportunity to present this small piece of work that highlights the natural history of degenerative spinal surgical pathology. So there's no conflicts of interest to declare. So the background to this is that all non-emergency spinal surgical procedures were put on hold due to COVID in March 2020. In June 2021, then there was a plan to remobilize elective spinal surgical capacity. And by this point, excessive surgical wait times had been created, as we all know. So there was a proposal put together for APP reevaluation of these patients that were waiting on the surgical waiting list and in over 18 months at least, to see whether they still required surgery. And of note, our full surgical elective surgical spinal capacity has still yet to be achieved. So the aim, as I say, of this evaluation was to identify those patients that still required surgery. Did their current symptoms correlate with updated imaging? Was the appropriate clinical priority associated with this procedure, or were they developing worsening neuro or deterioration in their functional capabilities? Was the planned procedure still relevant for their pathology, and did the patient still want to have an operation? So 179 patients were reevaluated. We've got full details for 163, and 43 of those patients, which equates to 27%, were removed from the surgical waiting list. The full details of the outcome of this reevaluation is highlighted in a poster in the main auditorium, number 37. Just put that out there. So a retrospective audit of the clinical notes was done on these 43 patients to identify the reasons for their removal from the waiting list, and primarily there was no longer a clinical indication for surgical intervention. So they had an improvement in their distal symptoms, or pathology had completely resolved, or in terms of the cervical myelopathy and neurogenic claudication type symptoms, their function had stabilized and at a level that the patient was then comfortable with. The other reason was that the patient no longer wanted surgery, and that was primarily due to the development of other health concerns or conditions. So the patients that were assessed and removed predominantly were lumbar spine patients, but did include some cervical, and they had an average wait time of 21.6 months on the surgical waiting list. So this was not the duration of their symptoms, but the time that from the point of entry on the surgical waiting list to the point of that reevaluation, not even to the point of surgery itself. So 21 patients noted improvement in their distal symptoms. 10 patients had continued symptoms but improved pathology. 6 patients had stable function. 3 patients developed other health conditions. 2 patients DNA'd despite several attempts by letter and telephone call to contact the patient directly. And 1 patient, which equates to 2%, sought to have their surgery overseas. So the group that had persistent pain but resolved pathology primarily were lumbar, although there was 1 cervical patient, and they had an average wait time on our surgical waiting list of 21.1 months. So the conclusions or the initial thoughts that we've derived is that 30 patients, 70%, were very satisfied with their non-surgical outcome, i.e. the process of natural history. So they had improved symptoms correlated with improved function. They had stable function that they were happy with and content with, or the decision to remove them from the surgical waiting list was in keeping with their own wishes. However, there were 10 patients, which was still 23%, where they had persistent pain and limited function and were not satisfied with their non-surgical outcome, i.e. they were not happy to be removed from the surgical waiting list, which did lead to some very difficult and challenging conversations. So this small piece of work may give us guidance to the appropriate timing of spinal surgical procedures to maximize any symptomatic and functional benefit, or it may highlight a percentage of patients that would not respond symptomatically to surgery. Thank you.
Thank you, Joanne. Any questions from the floor? I've got a question. In the abstract, you mentioned that 49% of the patients who were taken off the waiting list had improved symptoms. Do you think your study suggests that we are perhaps over-operating on patients and that we should wait for a longer time for the natural history to declare itself, and when we make patients wait longer, do you think we should be doing that?
I don't think that that's a conclusion that we can come from this, because it's about the timing or the duration of their symptoms and what functional impact that's had on a patient's life. We didn't look, or I didn't go back and look at work status, or whether at what point they'd gone back to work or gone back to normal function. So as surgery potentially is a short-term pain relieving procedure that allows people to return to their normal function at a much earlier stage, then we don't know whether that would have happened with those patients if they'd undergone surgery.
Thank you.
Any other questions? No, thank you very much.
We'd like now to call Fabian Wong to come and talk about his study, an anatomical predictor for safe pedicle screw length in spine surgery.
Good morning. My name is Fabian Wong. Thank you for having me today to talk to you about our work looking at the use of anatomical landmark to predict this maximum safe pedicle screw length in spinal surgery. We have no conflict of interest to declare. So it's important to use an appropriate screw length because an overlong screw run the risk of anterior breach, whereas a short screw mitigates this risk but affects the pull-out strength. And it should be an ability that can be used intraoperatively, that's easy to use, and will be a useful tool. So we hypothesized that there is a relationship between the interpedicular distance and the maximum safe pedicle screw length in spinal surgery. This is a single-center study over a 22-month period. We have two group patients. Group 1 are adult male and female patients with no spinal deformities, and the second group are patients up to the age of 30 with scoliosis. All patients had whole of thoracolumbar spine CT imaging, and any patients with trauma or previous surgery were excluded from this study. We have two independent assessors to measure the paired PL and IPDs from T1 to L5. The entry point we take is from the lateral aspect of the superior articulating facet along the center of pedicle on the axial imaging. And then we analyze it on the static studies. So here is an example of what we measured on a patient with scoliosis on a CT. On the bottom left, you can see the measurements across is the interpedicular distance. Along the, going up is the pedicle length. And here are bone models of what we're trying to measure. And they're showing the different shapes of the vertebral body on the right-hand side. So we have 20 male, 20 female consecutive patients, and 11 patients in the scoliosis group, and these are the demographics. We have good inter- and intra-observer reliability on our measurements. This is a graph showing our group 1, demonstrating the relationship between the pedicle screw length and the interpedicular distance. And when we analyze between genders, these demonstrate similar shape, and there's no difference in terms of the relationship between the IPD and PL. And in the scoliosis group, again, similar shape. What we have found is that the PL is consistently, so the maximum safe pedicle screw length is consistently greater than IPD between T3 and L4. The reverse is true for T1 and L5, and in the scoliosis group at T2 as well. And here are some of the models of the T1, low thoracic, and the lumbosacral junctions, showing why the morphological changes on the vertebra may explain our results. So our results support that IPD is consistently shorter than the maximum safe pedicle screw length when placed along the standard trajectory, with the caveat being in the extreme end of the spine. And it is easy to use anatomical landmark for doing surgery. Now, there are limitations. This is a small sample, and it is a radiologic study. And just because there are pedicle there doesn't mean that we necessarily need to put a screw through. And sometimes there may not be a pedicle. So in our conclusions, IPD is a valid and readily accessible anatomical landmark for estimating maximum safe pedicle screw length in spinal surgery, including in scoliosis correction. Thank you.
Thank you, Fabian. If I may just ask you a question as a jobbing DGH surgeon. You're sort of slanted towards the scoliosis patients, but can I extrapolate that work to my GGH work? And have you looked at perhaps whether you can glean that same information from an MRI scan? Because I don't necessarily CT all my patients. Is there some sort of a correlation there?
So we have not done the correlation between the CT and MRI scan, but our group 1 are basically patients without scoliosis, without spinal deformity. So yes, the anatomical relationship is there. Whether that can be done on MRI scan, I suspect, if we go by similar landmarks, it should come up the same. But obviously, this study only validates for CT, not MRI scan.
Mr. Lutchman.
Thanks for that work. It's very interesting. Quite often, if your screw's too long, it's 3 millimeters too long at the front, or 4 millimeters, and that can make a big difference. In terms of the error in your measurement of the interpedicular distance, what do you think your error in measurement is?
So it does depend. Obviously, this is a radar study, so it does depends on the software and the scanners in terms of resolution. So our next step would really be looking at using a intraoperative probe and actual patients' random measurements to see how it correlate clinically. But I suppose what is important is that what we're demonstrating is the maximum safe length without breach on the radiological. So you can always go shorter than that. You don't have to go the maximum length. What we're trying to say is that, for example, if you inadvertently go through the anterior cortex, sometimes it's difficult to find where the tip of the filler is. And therefore, you can take that as the IPD as estimate, a reasonable estimate for appropriate level for a safe length.
Thank you.
Any other questions? Thank you very much.
Thank you.
So the next paper is JAK inhibitor, and I'm not going to pronounce that because I've been practicing all night, so you can perhaps give us the education how to pronounce that biologic. Conversely regulates activate innate and adaptive interstitial immune cells by interfering with innate cell negative feedback, presented by Tom McLeod. Thank you.
Hi, yeah, I'm Tom McLeod, so apologies, this is a bit of a change of pace from everything else, I think. But I'm going to talk to you today about JAK inhibition in endothelial biology and immunology. So our lab is primarily interested in spondyloarthropathies within this ankylosing spondylitis and, of course, enthesitis, which is where one of the key lesions that we find across the spondyloarthropathies. And at the moment, the gold standard in therapy for spondyloarthropathies is biologics. These currently target key cytokines such as IL-23 and IL-17 in the pathogenesis of these conditions. But there are up-and-coming new methods of treating this, and one of which is through the use of JAK inhibition. And this has shown quite a bit of promise in therapy of ankylosing spondylitis, one of which is a JAK1 inhibitor called upadacitinib. There is a problem with JAK inhibitors, and that's that it's complex. People don't truly understand what's going on in terms of how they work. So just the graph here to show that there's a huge number of cytokines and receptors that signal through the JAK pathway. Understanding exactly what's happening and how the JAK inhibitors are having their effect on or in pathogenesis of these conditions is quite hard to unpick. But we've given it a go. So we're lucky enough in Leeds to work closely with a good group of surgeons, and these are happy enough to provide us spinal tissue to work on. So from the spinal tissue, we're able to isolate endothelial immune cells and then we can sort of emulate enthesitis in vitro. So we've done this with some of these enthesial tissue digests with upadacitinib, which is this JAK1 inhibitor. And we're able to activate both the adaptive and the innate immune system, and then measure cytokines that these cells produce in response. And we found that when we did this with T cells, the T cells are really strongly inhibited by a JAK inhibitor, so that the JAK inhibitor really strongly reduces production of IL-17 and TNF-alpha, which are really key in driving the pathogenesis of spondyloarthropathies. But in contrast, when you look at the myeloid compartment, we see the opposite, which is quite surprising, considering it's supposed to be an anti-inflammatory therapeutic. We actually get a really strong regulation of both IL-23, TNF-alpha, and IL-1 beta, which are all key in driving these conditions. So we wanted to have a look at a little bit more in depth as to why. And the first clue is in our model, we're using LPS to stimulate, which actually doesn't signal through the JAK pathway. However, LPS does stimulate a really important anti-inflammatory molecule called interleukin-10, or IL-10. And IL-10 does signal through the JAK pathway. So going off this, we built up a hypothesis that within our system, when we're stimulating these cells, as well as inducing pro-inflammatory mediators, we're also stimulating IL-10, and this is a key anti-inflammatory molecule which should be placing a brake on the pro-inflammatory potential of these cells. But we think when we're adding in a JAK inhibitor, we're potentially removing this brake and allowing the cells to produce lots of pro-inflammatory mediators. We're able to test this specifically by adding in an IL-10 receptor antibody, which specifically blocks IL-10 in this system. And by doing this, we demonstrate that we see a similar kind of theme. So we do see that when we specifically block IL-10, we get an increase in pro-inflammatory mediators. And conversely, if we add IL-10 onto a system which is blocked by a very small amount of JAK1 inhibition, we're able to reinstate this negative feedback loop. So just to conclude, it seems like the JAK1 inhibitors are really good at blocking the adaptive immune system, but not very good at blocking the myeloid system, and may even potentially make them worse and make it more responsive. So some implications of this: the success of JAK inhibitors in the spondyloarthropathies and enthesitis seems to indicate that these are going to be adaptively driven conditions. And conversely, if we have conditions that are strongly dominated by the innate immune system, JAK inhibition may not be so good to use here. So finally, I'd just like to thank people involved in this research, particularly the surgeons who actually provide this tissue, because without it, we wouldn't be able to do any research. So thank you.
Thank you. Any questions? Tom, thanks for your great presentation. In your abstract and in your presentation, you mentioned that the spinal tissue has been taken from patients with scoliosis and degenerative spinal conditions. Does it matter that the stimulation of these cells is on pretty much regular tissue rather than ankylosing spondylitis tissue? And have you repeated your study on ankylosing spondylitis tissue?
So for what we're trying to do, we're trying to understand the biology of the enthesis in its natural state. So we actually want uninflamed tissue. So that's why we base a lot of our work on this kind of tissue. We do also do a lot of comparisons between diseased tissue, but it's quite difficult to get hold of AS tissue. And when we do, we find that it's mostly completely ossified by the time people come to operate on it. So we can't get that much out of it in terms of cells. So yeah, mostly we do this on healthy tissue.
Thank you very much. Any other questions?
Thank you.
Okay, our next presenter is Andrea Nusch, and she's going to talk about gram-positive bacteria present in non-herniated human discs. What is their influence?
Okay, thank you very much for the kind introduction. So, as we all know, disc degeneration can be influenced by multiple factors, such as genetics and epigenetics, the biomechanics, the microenvironment, or other factors such as smoking and obesity. I am, however, mostly interested in the controversial topic of bacteria and their influence on disc degeneration. And this brings us to modic changes. Modic changes are vertebral bone marrow lesions that are visualized on MRI scans. And two different etiologies have recently been suggested. So one of them being an autoimmune reaction of the bone to the disc and the factor they secrete, and on the other hand, infection of the IVD. So recently, more and more papers get published with detecting bacteria within the disc, with C. acnes, a gram-positive bacteria that is usually on the skin, being the most abundant detected. However, most of the studies that detect bacteria either use 16S or RNA sequencing or microbial culture. And this tells us whether in the collected specimen there is bacteria, but it doesn't really tell us whether it's perioperative contamination or whether it's true in vivo disc bacteria. So therefore, our first question was, are there in vivo disc bacteria? And if yes, where exactly are they located? To approach this question, we get kindly provided with human disc tissue from the Sheffield hospitals. So we collect it, bring it into the lab under sterile environment, and then fix it and process it for staining, as you can see. So, and initially, we stained 75 human disc samples for gram-positive bacteria. We only included non-herniated samples to minimize the risk of contamination through the freshly formed fissure from the surrounding tissue. Here you can see some of our results. So in brown, you can see the bacteria, and in blue, the nuclei of the cell. And you can see that most often, so you can clearly see that there is bacteria within the tissue, but what you also can see is most often it's found near the nuclei of the cell. When we looked at all our samples, 90% of them contain bacteria in at least one cell. When we then looked at the percentage of cells, like out of 200, how many have bacteria internalized, it's around 4%, but ranging from 1 up to 10. So we did that blinded with not knowing the grading of the tissue, and so at the moment we investigate whether the degenerative state of the tissue is correlated with the bacterial presence. We also are staining now for specific bacteria, such for example Staph aureus, and for C. acnes, for example, it's ongoing, but you can clearly see that there was also bacteria detected. And it was observed that the morphology of the nuclei seemed to change when bacteria is present. And so our second question was like, what is the influence of bacteria on disc cells, or to make it easier, of bacterial components? So for that, we again get the tissue, but then we isolate, as previously shown, we isolate the cells, but and in our case, NP cells, we expand them and then stimulate them with bacterial wall components in 2D, so monolayer, and in 3D, alginate beads, which mimics more the natural environment. So we stimulate them with LPS, as shown before. This is from the cell wall of gram-negative bacteria, and with peptidoglycans from gram-positive bacteria. We then performed Luminex, a Luminex assay, which tells us the cyto and chemokine concentration within the collected media. So we did that, so you can see the control group, which is the non-treated group. On the left-hand side, only in 2D, you can see the LPS stimulation, and on the right-hand side, you can see the peptidoglycan treatment. And the more red it is, the more enhanced it is. And so you can clearly see that the peptidoglycan has a huge effect on those catabolic markers. As a third question, we then saw that many bacteria are internalized. So we looked at, are cells even able to internalize those bacteria? So for that, we did a core culture study. So we, at a multiplicity of infection of 1 bacteria to 100 cells, we infected our cell culture system for 1 hour before then washing it off. We stained our cells with phalloidin, so the cytoskeleton is red, the nuclei is blue, and we stained our bacteria in green. And we could clearly see that after 1 hour, the bacteria is internalized by the disc cells. Whether it's an phagocytosis from the disc or invading from the bacteria, we do not yet know, but we will investigate that further. So to conclude, we can say that gram-positive bacteria are present in intact or non-herniated human disc. Bacteria can trigger a catabolic response, and bacteria can clearly be internalized by disc cells. So with that, I would like to thank my whole team, Christine Lemaitre, my supervisor, and obviously all the surgeons who provide us with the samples. Thank you very much.
Thank you for that talk. I'll just start off. What was your average time from collection to final analysis? And are you confident that your process was watertight without the risk of contamination?
So we do collect our samples with pen strap in the media. So yeah, we are, because we will get, when we do the cell culture, we sometimes do get an infection of those cells. And then we can clearly see that this sample was infected like afterwards. But as we can see that the bacteria is like, when we grade the tissue, when it's on the edge, we state it as contamination. And when it's in the middle of the tissue, because we can see that when we section it, we would not state it as contamination because we'd rather collect them, rather fast.
Perhaps just a quick question. Do you think this is a simple, perhaps could be a mere random association or could be causative association with herniated disc? Have you looked at normal discs to see if there is bacteria internalized?
Yeah, we do have some cadaveric discs, and they also show the presence of bacteria. So at the moment, we are grading the tissue, or did you not mean that? No, you did mean that. So at the moment, we are really, like we did, H&D staining for the disc tissue, and from that, we then grade it, so histological grading on the degeneration, and then we try to either link that with the bacterial presence or not. Like, we don't know.
Just to clarify, did you say you also saw the bacteria in normal discs from cadaveric
Yes.
tissues?
But at a very low number.
Okay, and how about the subtype of bacteria? Is there a difference between abnormal discs and normal discs?
That we don't know yet.
Yeah, I mean, the reason I asked this question because I was getting excited here. I thought perhaps the next treatment for herniated disc is going to be antibiotics.
The problem with antibiotics, I mean, there were antibiotic trials, right? And it's a bit of 50-50, the outcome at the moment. And I think by having bacteria internalized by the cells, it's also differently protected than if it would just be within the extracellular matrix. You're welcome.
Thank you very much. It was a great presentation. So just following up, because I was going to ask the same question about normals. So for your normals cadaveric, did you say you did check if they were degen or not? So they were normal discs histologically, and you still had bacteria in them?
Some of them are, yes.
Okay.
Like we have some discs from, cadaveric discs from Montreal, which are considered as normal healthy discs, and we know that, and they are within the study.
Fantastic.
But we haven't yet made, like the connection will come later because we don't want to be biased by knowing this tissue is degenerated and then be like, oh, then I can see more bacteria.
And the second question was the distribution of the bacteria that you found. Was it different, or did you find that most of it's clustered to the back of the disc, or was it more towards the center of the disc, or was there no real?
I mean, we don't get usually a full disc, right? Most often we just get samples from like a microdissectomy. If we have the full disc, which are like rare because they come from the organ donors most often, I did not look at the location there, but within the others it's like distributed wherever.
Okay, thank you.
Andrea, can I ask a quick question?
Yes, sure.
So may I ask how the cadavers were preserved before taking that tissue? Could that have skewed your results? Because could the cadavers just be decomposed and that therefore bacteria contaminate the samples?
We did not only have cadaveric, you mean just on the cadaveric samples. So just in general, we have a lot freshly from the hospital. How exactly they are preserved, I do not know because I just recently started at this university. But I will follow this up with my supervisor. Thank you.
I've got just one comment. There have been innumerable studies looking at bacteria in discs that haven't found bacteria in discs, all sparked by the propionobacterium discussion. Are you using a new immunohistochemical method, or why are your results so you found a bacteria in 90% of your samples?
Yeah.
Why are your results so diametrically different from everything published in the literature?
I wouldn't say from everything published in the literature, first of all, but second of all, I think ours are different because we use a different approach. We are the first ones to do immunohistochemistry on the disc samples. We have a huge database in Sheffield with over 700 samples, and so we will do it with over 100 at the moment. Second of all, they used, for example, microbial culture. If you look at C. acnes is a highly anaerobic bacteria and it's slow growing. So if you don't give it enough time, if you don't culture it at the right conditions, you will not detect C. acnes. So I think it's like you need to have a lot of factors with, for example, the microbial culture that you get the right output.
Thank you.
Thank you.
Okay. For the last paper, it's Siram Srinivasan presenting evaluating a pathway for reducing multiple debridement for spine surgical site infections. Thank you.
Thank you very much for this opportunity to provide our work in this meeting. So that's our disclosures. So deep surgical site infections can be a very difficult problem to manage on a day-to-day basis, and it is quite challenging. The rates that has been described in the literature are up to 1.2%, which can lead to multiple debridements, which can be associated with significant morbidity and mortality, prolonged hospital stay, and the figures that has been quoted in the literature are up to 100,000 pounds per patient in NHS. So there is a paucity of literature of how patients can be managed with multiple debridements. And one literature which we found is the PITS model, which is an evidence-based model which has been published from North America, which predicts patients based on these predictors and the PITS score. And they stratify these patients based on low risk, high, and indeterminate group, which predicts their debridement into multiple debridements. So the aim of this study was to evaluate our SSI pathway in UHNM to reduce the multiple debridements and to compare and assess the PITS model with their predictions. So we retrospectively analyzed our prospective database over a period of 24 months, and we identified 54 patients who returned to theatre. We followed a UHNM pathway, which is every patient went through an infection MDT led by a dedicated consultant microbiologist. All patients had blood and tissue cultures taken. Metal work and was exchanged, and removal was recommended for the surgeons. Irrigation, about 6 to 9 liters of saline, was recommended. And based on our previous study, we aggressively treat patients with IV antibiotics until the CRP is less than 20. And then, depending on the microbiology advice, we switch it over to oral antibiotics. So we calculated, based on the PITS score, we calculated the score for our individual patients, and we used an SPSS software to analyze our data for the validity of our PITS. We looked at percentage success, cross-tabulation, and our chi-square tests. So we stratified our patients based on their PITS score into low risk, intermediate, and high risk. Looking at our cohort, based on the PITS, we expected that our indeterminate group and high-risk group, which is more than 60%, should have high multiple debridement. But looking at our results, we were able to manage successfully single debridements in more than 85% of our patients, and only seven numbers in our cohort needed a multiple debridement. More than 50% of our patients had implants which were exchanged or removed of metalwork. So looking at our results, instrumentation and diabetes and bone graft, which were thought to be high risk in the PITS model, which for multiple debridement, were not statistically significant in our group. We found that our sensitivity and positive predictive values were low in our cohort compared to that of the PITS model. So looking at our conclusion, we did not find PITS to be a useful predictor, because if you look at the PITS model again, they did not have surgeons modifiable factors in this cohort, so we didn't find that to be a useful predictor to predict multiple debridements. We found that exchanging metalwork had a trend to successfully treat our patients with single surgical debridement. We could not specifically identify a single factor which could associate with multiple debridement, but we do appreciate that our numbers are small. We found that our pathway was successful in treating our patients with single debridement more than what it was predicted. So what are limitations? We do appreciate that we did have small numbers. This is a single center trial, and we did only over a period of 2 years. So looking at our pathway, we think that we need to include more surgeon modifiable factors, which we could improve our pathway a bit better. And also, we thought we'd have to incorporate more or duration of our study if we can prospectively analyze these data over a period of time so that we can build it a bit better. So that's the reference for the PIT study. Thank you, and any questions for us?
Thank you for a very nice talk. If you look back at the PIT score, so clearly the PIT score wasn't particularly helpful to you and your institution. Which factors in the PIT score do you think are the ones that are flawed and may not be the ones that are pointing in the right direction?
So as I mentioned, the PIT score had more of the only factors that we thought was a bone graft, which they modified the bone graft into either an autologous bone graft or a synthetic bone graft, are the only body well factors a surgeon could change. Rest of them was diabetes, and there are no modifiable factors which a surgeon, as you and me, cannot change. So I didn't think that it was a good predictor.
Question at the back there. Oh,
Hi, Marcus Damatis from the Walton Centre. You describe your debridement and retention of implant. When you talk about exchange of implant, are you simply changing the rods, the caps, and the crosslink, or are you actually removing all your screws and replacing them?
No, we left the screws in, and the end caps, rods, and if we use crosslinks, that will change. Yes, sorry, I should have mentioned that.
And sometimes I note that if the bone graft's well fixed in an acute infection under 6 weeks, you're telling me that you wash it and leave what's there. Do you ever add additional bone graft with, say, calcium triphosphate and impregnate vancomycin or any other antibiotics?
So we don't use, we don't, our MDT pathway do not routinely advise vancomycin powder. So we leave it, we advise, the recommendation to the surgeon is a surgeon-driven intraoperative findings to act on it. So it's a recommendation rather than strong, robust pathway. Have I answered your question?
Absolutely. Thank you very much.
Hi there, Jim Bourne, I work at Preston. So I come from an orthopedic background, and an infection in joint replacements is very common. There's been a lot of work done on that in the US and also in the UK. With regards to DARES, which is debridement and implant retention in joint replacement surgery, there's a time window. And if you get to your DARE within 8 weeks, preferably sooner, then you stand a good chance of retaining your implants. You change what you can. So in a knee, you change a polyethylene spacer, but you keep the femoral and tibial components. That sounds like very much like the approach that you're advocating in a structured approach. So have you looked at timing as a factor?
As I said, our numbers are really low when we looked at it, and it is statistically it was not significant, but we think that it may make a difference. That is one of the factors we're looking at prospectively when we're going to do for future work. And our cohort, we did have early infection as well as late infection. So we promoted our pathway to exchange to see whether it works. And as I said, the numbers is less to advise on that.
Thank you.
Mr. Howes.
Yeah, there's a couple of points I'd like to make about it. The multiple debridements we see, we don't see it now because we've changed our practice, but if you let a junior fellow do the debridement, it's a disaster. They take 15 minutes, and you can't do a proper debridement in 15 minutes. Second thing we do is we marinade, 2/3, 1/3 betadine, fill the wound, leave it for 15 minutes, go and have a cup of coffee, then we come back. And then we irrigate after that. And with that, you can retain the metal in the majority of cases, in my experience. But the essential message is it's a long operation to be done properly. It's not a quick washout.
So I totally agree. As I said, our pathway mentions we routinely in our unit, we use 6 to 9 liters of saline, and we think that makes a difference, yes.
Okay, thank you.
Thank you. Any other questions? Thank you very much.
Thank you.
That draws the session to a close. Thanks for attending.